All right, so today FND Australia Support Services is talking to Dr. Baisbal, who's a neurologist from Mexico in the US, and he's going to be talking about the pathogenesis and pathophysiology of functional movement disorders. So you're the host now, so you should be able to share your screen. Oh, I've still got it. Yes. Awesome, thank you.
Well, yes, thank you very much for the invitation. Let me give you a brief overview of the pathogenesis and pathophysiology of functional movement disorders. I just want to clarify that these disorders represent one of the most important challenges in the understanding of the nature of these disorders. I just want to share with you this model that we have proposed, trying to separate what factors may be playing a role in the pathogenesis of functional neurological disorders. And for that reason, we have, let me take here, we have divided these factors in predisposing factors, triggering factors, and perpetuating factors. For predisposing factors, probably genetics and even epigenetics may play a role. However, the field is just, we don't have much information on this. The field is just starting to develop on this area. But we hope that in the future, we may identify some polymorphisms and some genetic variants that increase the predisposition of certain people to develop this group of disorders. Personality. So in the past, there were theories relating specific personality with development of functional neurological disorders. Well, this area is somehow controversial. The majority of information that we have now do not seem to relate a specific personality with the development of this group of disorders, but obviously we will need more information. And well, yes, psychiatric disorders are very common in patients with functional neurological disorders, but the problem here is that not all patients have clear psychiatric disorders, so we cannot identify a psychiatric disorder. So how psychiatric disorders contribute to the pathogenesis of functional neurological disorders, it's not clear. Then we have triggering factors, and it's very well known that trauma, yes, particularly physical trauma or mild physical trauma, is quite related to the onset of functional movement disorders and many functional neurological disorders as well. There might be social influences as well. Stress, this is a very controversial topic because most patients with functional movement disorders do not acknowledge stress. So when we start looking a little bit deeper on the psychodynamics of patients, it's not uncommon to find that these patients have stress. But the problem is that people that do not have functional neurological disorders also have stress. So why stress is related to the onset of functional neurological disorder and how it's related is something that is still unclear. Moreover, we don't have a biological marker that is highly reliable to assess and quantify stress. And for example, there are some studies that have checked the level of cortisol in the saliva and the blood, and have not found a major difference between patients with functional movement disorders and people without functional movement disorders. But anyway, these factors may be important to trigger the onset of this group of disorders. But why people that have an episode of so-called functional or previously known as psychogenic movements, they have more episodes, okay, in the future? You know, this group of disorders are cause very high levels of disability. They usually cause problems at work, with the family, etc. So people become very, very dysfunctional. So why these patients have these movements in the future once they have developed a single episode? And this is something that is not yet clear, but these perpetuating factors may be related to an abnormal neurophysiology, changes in brain connectivity, and even anatomic changes that have been currently identified in these patients. So if we put all these groups together, we can conclude that the disorder have a biopsychosocial basis, which is very, very complex. And let me advance. So going back to triggering factors. So there have been meta-analysis reports, etc., that have concluded that patients, for example, with functional movement disorders have a very high frequency of lifetime anxiety disorders. Almost 62% of them report an anxiety disorder. Personality disorders are as well common, but again, many patients with functional movement disorders do not have a personality disorder, and depression is also frequent. That's why when we have one of these patients coming to our clinic, we try to identify if they have any of these psychiatric disorders that we can treat. These patients also have higher rates of childhood trauma, which is mainly emotional abuse and physical neglect. It's not uncommon when we look a little bit deeper on clinical history. Physical trauma is fairly common, and particularly in patients with fixed dystonia. Those patients that come to the clinic with a fixed posture, for example, the arm, the hand, the fingers, they have a fixed posture that develops in a very short period of time, that suggests that the disorder has a functional basis. And about 2/3 of these patients have a history of physical injury. And this could be caused by lesion in the soft tissue, followed by limb overuse, fractures, operations, etc. However, if we put together all kinds of functional motor disorders, about 1/3 of those patients have a history of physical injury prior to the onset of the neurological manifestations. So, according to a meta-analysis by Stone. We know now that the type of physical injury is not related to the type of motor disorder. Social influences might not be taken too much in consideration when we evaluate these patients. But I just want to draw your attention for those reports of massive psychogenic illness, mass hysteria, that have been recorded through history for centuries. We think that this could be related to a phenomenon known as modeling, which we have defined as the adoption of certain behaviors or motor patterns following the observation of close individuals displaying such manifestations. Again, no specific vulnerable personality has been identified in these cases, but now there is some evidence that this process of modeling may be related to the onset of this manifestation. And this is important because patients with organic neurological disorders, organic movement disorders, may have also at the same time functional movement disorders. For example, a patient with Parkinson's disease may have functional slowness. And this could be an example of self-modeling, where the patient models himself or herself, and the manifestations of the functional neurological disorder may be related to the symptoms that the patient has because of the organic disorder. I remember some years ago, we saw a patient that had chorea. You know, chorea is not a common manifestation of functional motor disorders. It's quite uncommon, but the patient looks like having a severe case of Huntington's disease. And the patient acknowledged that she had family members affected with Huntington's disease. And she was tested 3 times for the Huntington gene, and she tested negative the 3 times. So, and that patient was published in Movement Disorders by a close friend of mine, Dr. Robert Facchetti. He published that patient in Movement Disorders. So it may happen. So we need to take this into consideration as well. But the main problem with patients with functional motor disorders is that they seem to have the motor produced by the motor pathways related to volitional movements. So, but they swear that the movements are involuntary. And that could be the main mystery of this group of disorders. Why movements that look voluntary, they might be distractible, patients have suggestibility, and even from the neurophysiological standpoint, they have the Briggs-Shaft potential, which is a potential that originates in the premotor cortex and is related to voluntariness. And patients, for example, with organic myoclonus do not have this Briggs-Shaft potential. However, patients with functional neurological disorders have this potential, suggesting that the movements are originated following voluntary motor pathways. But they do not recognize them as such. So they say, no, this is involuntary. So they don't have this, they somehow lose the insight to recognize the movements as involuntary. So they are not manipulating. They are not manipulating the family. They are not manipulating the people around them, doctors, etc. They truly have the movements an involuntary nature. And using different paradigms of fMRI and PET-CT, now we have a lot of evidence that areas related to motor control have decreased activity in patients with functional neurological disorders. And it's very interesting to see that the dorsolateral prefrontal cortex, the sensory motor cortex, and this area, the right temporoparietal junction, which is nearby the angular gyrus, have hypoactivity in patients with functional neurological disorders. On the other hand, areas that are related to self-monitoring, self-awareness, like for example, the cingulate cortex, the precuneus, the ventromedial prefrontal cortex, and areas related to emotional control, for example, the amygdala and the preaqueductal gray matter, have increased activation in these patients. For the thalamus and the basal ganglia, it's somehow complicated because patients with functional paralysis have shown that have decreased activation. But patients with functional movement disorders have increased activations of the thalamus and the basal ganglia. So all this suggests that there is a shift in the function of the brain moving to self-monitoring, self-awareness, and a decrease in the activation of the motor areas related to volitional control, even if the patient have hyperkinetic functional movement disorders. The cerebellum seems also to be increasing activation. So the connectivity between these areas has also changed in these patients. For example, there is evidence that there is decreased connectivity between the right temporoparietal junction and several motor areas, including the ipsilateral insula. On the other hand, there seems to be a hyperconnectivity between the pericingulate cortex, and this is related to as well increased connectivity between the amygdala and the supplementary motor area. The supplementary motor area is an area which is devoted to preparation of movements. So, and the amygdala is related to emotional control. So we have proposed this model just to exemplify how all this dysfunction in several areas can contribute to the whole picture of functional motor disorders. And when we move, there is a conscious experience. First, the first part of this conscious experience is the diverse feelings or motivations that we have to move. Then we have the intention to move, and this is followed by the action itself and by an outcome. And this is obviously linked with neural events that are related to activation of limbic network. The intention is related to motor preparation, okay? The action to the movement itself, and the outcome to the sensory effects that cause the movement that are registered by proprioception. And if we go to the anatomical basis of the neural events, well, we have the amygdala first, and then we have for motor preparation, the dorsolateral prefrontal cortex, the supplementary motor area, and the pre-supplementary motor area, and for the movements, the primary motor cortex. And for the sensory effects, the somatosensory and parietal cortex. Well, now we have evidence that all these elements of the equation may be abnormal in this patient. So we just saw that there is an abnormal patterns of activation of the amygdala. We know now that there is hypoactivity in functional dystonia, for example, in these areas, the supplementary motor area and dorsolateral prefrontal cortex. And some patients may even have absence of the brain shaft potential, which is originated in these areas. The primary motor cortex as well, we just saw that this is functional. For example, there is evidence of hypoactivity in functional paralysis and fixed dystonia. And the somatosensory and parietal cortex, well, as well, there is evidence of abnormalities in sensory attenuation, perception of body position, temporary discrimination threshold, etc. for the sensory abnormalities. But what about the relationship between the intention and the outcome of a movement? So there is a process that occurs in the brain that is called the binding effect. The binding effect is a compression that our brain does automatically every time that we move, a time compression that is observed here between the intentions and the outcome of the move. So when we have this compression, this originates a self of agency, which means that a movement that is performed, the subject recognizes it as self-intention or part of our intention, an outcome of motor program. But if this normal binding is reduced, for example, here, in this line that is reduced, so the prediction and the retrospective inferences of that movement may be abnormal. And this creates an abnormality in the sense of agency. And what is the anatomical basis of this? Well, as well, the pre-supplementary motor area and the supplementary motor area, but importantly, the right temporoparietal junction. And as I just show you, hypoactivity of the right temporoparietal junction, decreased connectivity with this area and the ipsilateral motor areas seems to be related to these abnormalities between intentions, the motor plans, and predictions. So, and this can cause an abnormalities in the sense of agency. But also for the sense of agency, we need the intention, the will to move. And that seems to be also abnormal in patients with functional neurological disorders. What is interesting here is that a lot of information that we have regarding how the pathophysiology works has been done with paradigms, fMRI paradigms, testing normal movements. So it seems that there is somehow of underlying change in the neurophysiology that might be present even in the normal movements of the patient. Because, you know, we don't test these abnormalities well while the patient has an episode of severe tremor or an episode of severe dystonia or of functional myoclonus, etc. So the problem here is that we still don't know if these changes, let me go back to this slide, if these probably perpetuating factors are really perpetuating factors. There may be predisposing factors because we don't know if the repetitive movements that the patient have cause these abnormalities in neurophysiology, brain connectivity, and even anatomical changes, or they result from the or they cause the movements, or they result, they are the byproduct of the repetitive movements. That is unclear, and we still are speculating on this because just to understand this, to solve the mystery, we will need to do, for example, check the connectivity and neurophysiology of normal people and follow them in time. And this will be extremely complicated, extremely difficult to do in a study.
So in the study, do you look at how long the person's had the illness? Like, does having the illness for a longer period of time lead to more changes in the brain than someone that's had the illness for a short period of time?
Yes, that is an interesting question because there is no clear relationship between the evolution time and even this and the neurophysiological changes or the severity of the movements. Because, you know, some patients may have functional neurological disorders that are very, very severe, are very constant, etc. And that doesn't seem to be a main factor to figure out if patients have more severe abnormalities. Sometimes, you know, patients may improve even spontaneously. We have seen that, or with treatment. And we don't have studies that follow these patients. These kind of studies have not been done prospectively to follow patients, what happened to the neurophysiology after the patient improves.
Yeah.
That would be very, very interesting, but we still don't have that information.
Yeah.
So I just forgot to mention that this hyperconnectivity between limbic networks and motor networks, as I point here, seems to be related as well with abnormal processing of emotional sensations, and maybe with this hyperconnectivity between the limbic and the motor may be expressed in a different way compared to normal subjects.
So why does it impact people in different ways, though? Is it because of the way that the brain has processed it, or like, you know, some people can't walk at all, they're in wheelchairs, some people walk but they're very unstable in their walk, or is that just a progression?
Okay, yes, well, what we usually see is that patients with functional neurological disorders have are very, very impaired since the beginning. So yes, some patients may have a progression in time, but it's very, very common that patients reach a high level of disability since the very beginning of the disorder. So, for example, if you see a patient with the so-called aesthesia, these patients cannot walk suddenly. They usually describe that way. Well, I was okay and at a particular time, and after that time, I was not able to walk. That is a particular point in patients with functional neurological disorders, that many patients can describe exactly the time that the disorder has begun, which is very, very uncommon in patients with organic movement disorders. They say, well, it's been a year, 6 months, etc. But functional neurological disorder is different because they can describe what they were doing, and they can describe the exact time that the movement started.
Okay.
And yes, now the problem goes even further because we can say, well, okay, maybe the function of the brain changes, but this is reversible. So for that reason, many neurologists try to explain this group of disorders as a change in the software. People explain to patients, well, imagine that your brain is a computer, and what is happening to your brain is malware or a software that is not working properly. But if we open your school and examine your brain, everything will be normal. But it turns out that is not the case. So there is now evidence that, for example, increased cortical thickness in the bilateral premotor cortex in patients with functional hemiparesis, or cortical atrophy in patients with functional seizures. And also the basal ganglia and the thalamus may be altered and have decreased volume compared to normal people. So yes, if we analyze macroscopically the brain, it may look normal. But if we do volumetric assessment of several areas, particularly the gray matter, we will find that this is abnormal as well. Why is it abnormal? Does this result from the movements, or are there people with abnormal gray matter volumes that are vulnerable to development of functional movement disorders? So that is a question that is still unsolved, but the field is moving that way. So try to assess what was first, the egg of the chicken.
Who came first?
So
Dr. Baisbal, does that include lesions on the brain as well in that volumetric change?
No, nothing that you can see on a normal MRI. So if you do a 3 Tesla, for example, MRI on these patients, you will see that everything is normal. So for that reason, many psychiatrists usually tell these patients, well, you need to go with neurologists because you don't have a psychiatric problem. This is a neurological problem. The problem is that when patient goes with the neurologist will tell them, this is not a neurological problem, this is a psychiatric problem. So
Yeah,
this group of
exactly.
disorders are still a little bit between both fields, but they seem to be moving to the neurological field. For example, we recently published a patient with functional dystonia and functional stereotypies presenting during sleep. And this is very, very well documented. So if the movement in a patient presents during sleep, how can you say that this is psychological?
Yeah, exactly.
There must be something wrong in the neurophysiology of this patient.
Yeah.
But for centuries, you know, at the beginning, the theories of hysteria and the relationship of these movements with female sex, etc., was obviously those ideas were changed basically by Charcot and another important neurologists or in the history of medicine. Now we know, for example, that men have very high rates as well of functional movement disorders. We published a study, I believe, 1.5 years ago, 2 years ago, comparing patients with males and females with functional movement disorders. And after 50, the age of 50, the frequency of functional movement disorders is equal. And you know, there is recently a study led by Dr. John Stone and Sarah Lipstone of thousands of patients with functional movement disorders that seems to point that this is the case. So about 30% of patients with functional movement disorders are males. But this relationship seems to be almost 50-50 after 50 or 55 years old.
So what is underlying that? Is that potentially hormonal influences? Or is it just that men are underdiagnosed?
We don't know. I don't have an answer.
I've also heard that children, that very, very young children, they're like 6-9-year-olds,
somebody can
equal male, female. And then from puberty up to about 50, it's greater female. And then it's 50-50 male, female.
Yeah, some can argue that endocrine influences may be related, or normal aging of the brain may equal the vulnerability of male and female brain to this group of disorders. We still don't know.
Because it's you hear it more and more now that it is impacting a lot of the younger ones from the age of, I'm talking in the 5 to 12 teenagers. Is that driven by hormone, or do you believe, or do you know have you done much study in that?
Yes, we don't have much information on that. It could be, but we still don't know.
Because talking to the people that I've spoken to who have children with FND, for instance, they seem to find that because they come under the pediatric side of care, they're almost ignored at times. You know, it's just a child being a child. No, it is really
reinforcing their behaviour.
Yeah, reinforcing their behaviour. That's right. And it is really interesting to see that, as you said, after the age of 50, it becomes more 50 and 50 male, female, whereas earlier, what are the numbers between 50 and, say, 25 male to female? Do you know that?
Between
25 and 50?
Or it's 70% female.
70% female. Okay.
70%.
Yeah.
Female. Yeah. But we still see males with this group of disorders. So
oh yeah, I know so. Yeah.
So it's something that Charcot pointed out since the late 19th century in La Salpêtrière, which is also my alma mater. And yes, and since that time, it seems to be more recognized in males. So I have seen lots of male patients with functional movement disorders.
Can I ask, in your experience with patients with FND, what would you predict would be the percentage that do recover?
Oh, yes. This is a very, very interesting question because it depends a lot of the evolution. If you see a patient at the clinic that comes to you and tells you, well, I have had these movements for 10, 15 years, it's going to be very unlikely that that patient recovers. If the patient tells you that she or he has had the movements for 1 month or 2 months, well, the rate of recovery will be very high, probably 80 or 90%. So now we know that the evolution time is quite related to the prognosis.
Yeah, and that would
And for that reason, it's very, very important to identify these patients early and try to provide some kind of treatment as soon as possible. Make them understand what the disorder is and what they are facing, and try to be caring with those patients. Yes, but depends a lot on that. I can tell you that even patients that 1 year of evolution or 2 years, they have very high rates of recovery. But usually when you see patients that 10 years, 15 years with the movements, oh, it's going to be very difficult.
Have you seen patients who have actually evolved from that FND into things like Parkinson's and that?
Do you mean patients with FND and Parkinson's?
Yeah, is there a correlation? Is there a correlation between those, or?
Well, we know that now that patients with Parkinson's disease, there are some papers that have been published that patients with Parkinson's disease have a relative high rate of functional neurological disorders. And when I first became aware of this information, I was very, skeptical. And I thought, no, I don't think that's that high. But in my experience, because I see a lot of patients with Parkinson's disease, there are many, many patients that sometimes it's difficult to explain some of the symptoms that the patient has, and those symptoms may improve suddenly or spontaneously. So that makes us think that that patients with Parkinson's disease have have a high rate of functional movement disorders. And by the way, I just finished a study. This has not been published, so I cannot give you exact information on patients with Tourette syndrome. So we just made a study with hundreds of patients with Tourette syndrome. The frequency of functional movement disorders was surprisingly high as well.
Oh, yeah.
Because some of our
So
members
we are just preparing
tics.
the paper for to submit to journal, but I can tell you this as well, that patients with Tourette syndrome have a high frequency of functional movement disorders as well. And just to make this more complicated, some patients with what it looks like having organic tics may have functional tics. Yes, in 2013, I think we were the first to describe functional movement disorders resembling tics. And even we have published some videos of patients that if you see them and you have some experience with Tourette syndrome, you will swear that those patients have Tourette syndrome. But it turns out that those have a functional tics. and it's very difficult to recognize between, for example, functional tics and organic tics. And one clue that we realized that is very, very important is that patients with organic tics can suppress the tics at least few seconds. If you tell a patient with Tourette's, do not tic, the patient will hold his or her tics few seconds and then will start ticking. But patients with functional tics cannot hold the tics. So if you tell them do not tick, they will still ticking. That is interesting, and it's interesting as well that patients with functional tics may have sometimes uh, premonitory sensations as well as patients with Tourette syndrome, which makes this very, very enigmatic. So we don't know if this could be a form of modeling, patients that saw another patient with tics and then they start ticking even if they don't have Tourette's, or if there is something else. But also one of the main mysteries is why a patient with functional movement disorders develop tics, why a patient develops tremor and another develops dystonia, fixed dystonia, or myoclonus jerks, etc., or Parkinsonism. We still don't know because the studies that have been done, that I just show you an overview, have been carried out in a relative limited number of cases. And most of these cases have tremor and dystonia, which are the most common functional movement disorders. Yes, so this is how it goes.
It's a very interesting subject. I have experienced some of the tics that you talk about, and at one stage they were almost bouncing me out of the bed. But the correlation between the two is something that I wouldn't mind delving into at another stage. I do have to apologise because I've got another place to be at 10 o'clock our time here in Australia, but I'll leave you with Kate and the other ladies. It's nice to meet you though, Doctor. And
Nice meeting you. Thank you.
It's my name's David anyway, David Bond. But
Thank
it's
you
been
very
very,
much.
very interesting. Thank you for your time.
Thank you very much.
Bye, Dave.
Okay.
I don't-
Bye-bye.
Bye.
Can I ask another question?
Sure.
Have you seen any familial expressions of FND, thinking along the lines of, say someone has an organic thing like Parkinson's, so say that's the grandmother in the family, have you then seen people in the generations below with functional neurological disorders in your experience?
No, this is a very interesting question. I personally have not seen that phenomenon, but there are reports of functional movement disorders in families.
Yeah.
We don't know.
I was just
if
going to
the-
say, I asked because my mother has Parkinson's, which was early onset, age 53. So she's in her 70s now, and it's my daughter that has the functional neurological disorder, and she's only 19.
Yes, we don't know if this is related to a particular vulnerability, predisposing factors, as I just mentioned.
Yeah.
The genetics in that family, or is this a form of social influence?
Yeah.
So, or even both. Why not?
Mm-hmm.
They are not
is that,
mutually exclusive.
Sorry, Dr. Jose, is with modeling, is it this as a social influence, is it voluntary or is it unconscious? Is it something people do on purpose, and is that why it's been considered for so long as a factitious disorder, or malingering and faking? Is that where that connection comes in?
Yes, very, very important question. So we need to differentiate between factitious disorder, where the patient do the movements trying to obtain a secondary gain. So these patients try to manipulate, they try to obtain something by, doing movements, etc. That are factitious disorders. In my experience, I do not see those kind of disorders in my clinic. And in my neurological experience, they are uncommon. They are very uncommon.
Yeah.
When you see a patients with these movements, and you ask them, are they voluntary or involuntary? The patient will swear that the movements are involuntary. As I mentioned before, even if they cause severe disability and severe impact in quality of life, we know that the impact in quality of life is as high as, or even higher compared to patients with Parkinson's disease. So just to imagine how the severity of this group of disorders.
Yeah.
And they are not trying to manipulate anybody. But if when they arrive to the ER of any hospital, many doctors that come to see those patients think that the patient is manipulating and start treating the patient, let me express it this way, but badly. And the patient perceives this treatment by doctors, by nurses, etc., and start having conflicts with a lot of medical staff.
Yeah,
it causes a lot of
many
harm.
hospitals.
Yeah, it does.
And that adds stress as well. And if you tell in front of any of these patients that they are trying to manipulate, they think they trying to do all the things, you are going to offend them.
Yeah.
Because again, one of the main mysteries of functional movement disorders is why a movement that looks voluntary is perceived by the patient as involuntary.
And does that relate to that motor cortex being, underactivated? You're talking about, that hypoactivation in the motor cortex?
Yes, we know that with fMRI, PET scans, these patients usually show hypoactivation compared to patients with controls, even if they have a hyperkinetic movement disorder. The difference is in patients with paralysis, because patients with paralysis, they have hyperactivity of the basal ganglia or the thalami, but hyperactivity in patients with hyperkinetic movements. So we know this not from different studies, but studies patients with hyperkinetic movement disorders are consistent with hyperactivity of areas related to movement or planification of movements, or movement planification, like the supplementary motor area or the dorsolateral prefrontal cortex. So these areas are involved in movement planification and execution. So why it happens this way is unclear, but observation that the cerebellum is usually hyperactive in these patients seems to probably be a phenomenon of compensation. If you have a hypoactivity here, you may have a hyperactivity in the cerebellum to compensate, to stimulate the cortex, and try to compensate this decreased activation, because the hyperactivity of the cerebellum is more or less consistent.
Do you think in the future that there will be tests that will be able to diagnose patients based on that hyperactivity and the volumetric changes that you saw, so that there's just more than a positive Hoover sign to check whether the person has FND?
This is another important question, because we don't have a biomarker of functional motor disorders. We don't have a biomarker that tells us about the diagnosis and how severe the patient may be. And these studies have been done comparing patients with controls. So, you know, if you do one study, it's meaningless. So you need to do a group of patients and have a control and compare. Obviously, age and gender match control in order to understand if there are not confounding factors. In order to avoid confounding factors, but that's the way it works. So again, if you do one study, it won't help. So these studies have been done basically trying to understand the pathophysiology and the underlying abnormalities in patients with functional movement disorders, rather to classify them by a diagnosis. So,
so do you think future research will go down that line more, in trying to get a lot more studies done in that area, or try to do longitudinal studies where you've got patients that you can do that for?
Ideally, we should have...
My words are not working.
Ideally, we should have... a study should see patients with a particular movement disorder and not mixing dystonia, Parkinsonism, tremor, myoclonus, gait abnormalities, etc. So ideally, we should have patients having the same clinical expression of the functional movement disorders. And once that we have enough number of those patients, we will start comparing these groups and see if there is any difference between a particular expression of the disorder. I don't know if that was the question, but again, if we go if we go to the studies, we will realize that this happens, except in patients with paralysis, because patients with paralysis have a more homogeneous presentation. But if you see, for example, patients with functional movement disorders, you will realize that these patients have a tremendous variability of phenomenology. You may find a patient with a facial spasm, and another patient having jerks, and another patient unable to walk.
Yes, it's very diverse, complicated. I understand how difficult it is to try and pin it down to do.
So again, maybe paralysis could be one of the motor manifestations that might be, in that sense, easier to study. But in my experience, motor paralysis is not common. It's more common to see hyperkinetic movements rather than paralysis. I don't know why.
I have paralysis. Yeah, I have paralysis.
You have
comes
paralysis.
crossover with a migraine. So
Okay.
they're very, developed through
But
medication.
Is it functional paralysis?
Yes, it lasts
Okay.
from between 3
Wow,
hours
very,
to
very interesting.
16.
Yes, I have seen patients with functional paralysis, very severe functional paralysis.
Yes,
But
it's quite
it's
disturbing.
not the most common. Hyperkinetic movements are more common
Okay.
than paralysis. Okay, maybe 1 or 2 patients every 10 patients with, 1 or 2 patients with paralysis and 10 patients. Yeah.
Okay.
Maybe that relationship.
That's fairly uncommon
Also,
then, isn't
we
it?
don't know if in different areas of the world the presentations may be different. So when I did my research and fellowships at Baylor, the patients that I saw there were somehow different compared to the patients that I see in Mexico.
Okay.
We
You
see
think
So-
environment
That is
plays a
another.
part?
There are some studies that seem to point that there are no major changes in phenomenological variability if you consider different geographic areas. But in my experience, I feel that there are some variabilities.
That's interesting.
With neuroplasticity and people with sort of the younger brain, the brain still growing and developing, do you think with treatment, their brains could improve so that they don't have these hypo and hyper activations?
Yes, I believe that may happen, but again, we don't have studies assessing what happened to the brain of these patients after treatment.
Yeah.
It would be very, very interesting to do before treatment and after treatment. Once that the movements completely resolved, that would be very, very interesting. Because if the abnormalities are still there, that would suggest that they maybe even be there before the movements start. Why not?
Yeah.
What about any inflammatory role? Have you found any relationship with inflammation in the nervous system?
This is another important question. We don't have now information about inflammation, but I believe that there might be some systemic inflammation in patients with functional movement disorders. It could be related to abnormalities of the microbiota, the gut bacteria. So I suspect that in the future we will have a lot of information about this. But I suspect that these patients have dysbiosis because these patients have usually other forms of functional disorders, like irritable bowel syndrome,
I was going to say celiac disease.
migraine. So other disorders where abnormalities in the microbiota and gut bacteria have been detected in a high frequency of patients.
Yeah.
So for that reason, I feel that in the future we will have information that these patients may have a high frequency of dysbiosis as well. And if they have a dysbiosis, this could cause systemic inflammation.
Yeah.
Mild form of systemic inflammation.
Yeah. That's another family thing in our thing. We have a lot of autoimmune disorders like lupus and rheumatoid arthritis and one person even has a vascular inflammation of the central nervous system, which has left him in a wheelchair. So a very high probability, I guess.
So I think I have to leave.
Yeah, thank you very much for your time.
Thank you very much
Yeah.
for the invitation. My pleasure meeting you, Dr. Jill and Ms. Moore and Sherry. Whenever you want to talk, just let me know. We
Wonderful,
can
thank you.
schedule another
Yep. Awesome.
another
Thank you very
meeting.
much.
It's really my pleasure. I have friends in Australia as well. I don't know if you know Dr. Andrew Hughes.
No, don't think so.
Andrew, no?
Yeah.
Well, he's a very well-known
Okay.
neurologist in Australia. He's a good friend of mine. We share office in La Salpêtrière. Well, he was doing some, I think that his sabbatic year in France some years ago.
Yeah.
We met there, and yeah, so
Maybe you could
whenever
share.
you want, we just let me know.
I was going to say, maybe you could share his details so we have another contact in Australia.
Thank you. Thank
All
you.
right, well, yeah.
On his,
Thanks so much.
Alex Len as well.
Yeah,
I
we
think
know
that
Alex Len. Yep.
Yes,
Yes.
Alex
Yep.
Len.
Alex Len is our big FND specialist. Yep.
Yes.
All right. Well, thanks so much for your time, and
thank you.
we'll talk
Thank
soon.
you.
Okay.
Thank
Bye.
you.
Bye.
Have a good one.
Bye.
Bye.